and I'm very happy to welcome you to today's webinar hosted by VitaFlow, titled The Nutritional Management of the Child with CKD Stages 2 to 5 and on Dialysis. This webinar aims to support healthcare professional education with regards to the dietary management of paediatric kidney disease. A few housekeeping items before we get started. The webinar is intended for healthcare professionals only. It will last approximately 90 minutes and will include time for questions at the end. If you'd like to ask a question, please use the question feature on your screen. All questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar is being recorded and will be available on VitaFlow's website for healthcare professionals in a few weeks' time. PDFs of the presentation slides are available on your screen for downloading, and a certificate of attendance and a self-reflection tool will be sent out by email after the webinar. The views herein are of the presenters and do not necessarily represent VitaFlow's views. The material is accurate as of the date presented and is for educational purposes only, not intended as a substitute for medical advice. The learning outcomes for the session are documented on this slide. We're fortunate enough to have a host of experts included in today's webinar session. Vanessa Shaw is an honorary senior lecturer at UCL Great Ormond Street Institute of Child Health and was head of dietetics at Great Ormond Street Hospital for Children, London until 2017. Vanessa is a reviewer for Paediatric Nephrology and Journal of Renal Nutrition and co-chair of the Paediatric Renal Nutrition Task Force. Jetta has worked for over 10 years as a paediatric renal dietitian. She is currently working as a clinical lecturer in the University of Eastern Finland. She's a founder member of the Paediatric Renal Nutrition Task Force and has gained a PhD in nutritional epidemiology. She's involved with ongoing research in the field of nutrition and dietetics in children with regards to disease-related malnutrition, renal nutrition, nutrition in short bowel syndrome, and nutrition after organ transplantation. Our chair, Dr. Fabio Paglialonga, is currently a paediatric nephrologist at a key children's centre in Milan, Italy. His main areas of interest are the assessment of dry weight and cardiovascular status of children on chronic hemodialysis, the nutritional status of children with chronic kidney disease, the management of the vascular access for hemodialysis in paediatrics, and therapeutic apheresis techniques. Dr. Paglialonga has been a member of the ESPN Council since September 21 and of the ESPN Dialysis Working Group Board since 2019. He participates in the European Paediatric Dialysis Working Group and is the current chair of the Paediatric Renal Nutrition Task Force. Without further delay, I'll hand you over to our speakers to start the webinar.
Hello everybody. Today Jetta and I are going to be taking you through these clinical practice recommendations that we've had published over the last few years and how they relate to the child with CKD. We did a similar webinar last year in how these CPRs relate to an infant, but now we're going to move on to children over 1 year of age. All of these clinical recommendations have been published in Paediatric Nephrology. They're open access and they're available on the ESPN website that you can see there at the bottom of this slide. We're also going to be sharing with you, next slide please, the practical guides that we've also written. These take the main points from the clinical practice recommendation papers, and they're written in a very practical fashion, and they're geared at dietitians, doctors, perhaps nurses, any member of the team who are actually seeing a patient in clinic or at the bedside, and they can be used to give very practical advice for families and the children that we're seeing. Next slide, please. We've also developed a number of diet booklets and posters for families. We have a suite of booklets about potassium and another about phosphate. And we have developed various posters which outline foods which are high, moderate, and low in both potassium and phosphate. And these are all available on the VitaFlow via website. And indeed, the posters are interactive. So if you haven't already discovered these, then I would recommend them for you. Next slide. In the last year or so, we have had a lot of international collaboration, and we now have our information available in various languages. For Poland and Lithuania, we have pretty much a straight translation of the diet booklets for families, but we have the Arabic and Indian food guides. Not only are these translated into local languages, but they also feature local dishes, local composite dishes, and the dietitians in those countries have worked very hard in analysing such typical meals that are available for kids and families in their country. And these can be used, obviously, for families who have moved from the home country. They're not just relevant for those that live in the Middle East and in the Indian subcontinent. And again, the posters that you saw in the last slide, these have been adapted and translated into Arabic and German. So you have a good selection here of resources which will help you when you're advising families and your patients. Next slide. So let's just start off with something that you have heard before, and I probably don't need to tell you again that providing adequate nutrition is essential in children with CKD. Not only in the infantile phase when growth is predominantly nutrition dependent, but adequate nutrition has more long-term consequences on linear growth. We know that these children have an abnormal body composition with a high fat mass and low lean body mass, and they also have increased central adiposity. So we have to think about the nutrition we're giving them. Is it setting them up for metabolic disease as they get older? We know that nutritional adequacy contributes to improved cognitive outcomes, but we don't know whether this is related to the age of onset of CKD, the duration of the CKD, or indeed if there are any comorbidities. But I think what's important to point out is this new information that's come from the ESPN ERA registry about transplant and growth. And the findings here are that both short and tall stature and being underweight are associated with the lower likelihood of receiving a kidney transplant. And indeed, mortality is higher in those on kidney renal therapy if they have short stature, if they're underweight or obese. So I think this just magnifies again how important nutrition is on growth and outcomes for these children to be transplanted later in life. And just to say that that period of vulnerability of poor nutrition is extended in CKD because the infantile phase of growth may not end at 1 year of age, but may be extended to 2 to 3 years of age. So continuing good nutrition is of vital importance. And put together with that many infants are already disadvantaged in that they're born small, they're either premature or they're small for gestational age. And that constituted a large number of children in this study that we published from Great Ormond Street in 2010. Next slide, please. So before we can think about what the nutritional prescription is for a child, we need to undertake a nutritional assessment. And again, we have a full clinical practice recommendation paper on this. But we need to think about anthropometry, that there are 3 key measurements: euvolemic weight or dry weight, length, and head circumference for those children under 2 years of age. And all these measurements should be plotted serially on WHO centile growth charts. And it's also very useful to calculate their Z-scores to complement those growth charts. BMI and weight for length are also very useful because obviously they will show whether there's underweight or overweight. And we concur with WHO that weight for length is used for children aged 1 to 5 years and BMI for those over 5 years. We recommend that these are plotted on WHO growth charts, but if you have country-specific charts, they can be used for children over 2 years of age. But we do recommend WHO charts for those under 2 years of age. Along with anthropometry, part of the assessment includes a dietary assessment, and this can be either conducted as a 3-day diet history or 24-hour recalls. And just to remind everybody that biochemical assessment, the only validated biochemical measurement for nutritional status is actually NPCR in adolescents that are on hemo. Albumin is sometimes used, but it should only be used as a measure of nutritional status after any non-nutritional causes of hypoalbuminemia have been excluded. Don't just look at albumin alone and feel that that's telling you about the nutritional status of your patient. Next slide. So let's meet Daniel, who is a little boy who Jette is going to be presenting to you over the next hour, and seeing how his history goes and how we can fit in his management with the recommendations that I've already mentioned. So Jette.
Thank you, Vanessa. It's nice to be back here. So let me introduce you to Daniel, who is our example patient today. He came to our nephrology unit because of edema, and he also had a mild motor developmental delay. Initially, he presented with hypertension and proteinuria and microscopic hematuria, and his albumin was quite low, only 12 at this point. His condition was resistant to steroids, so he was started on non-cyclosporine and albumin infusions. As Vanessa just mentioned, we obviously took Daniel's weight and height when he came to us. Here on the left, you can see his height, which had been around -1 SD and then was slowly declining towards -2 SD when he came to us. And on the right is his weight plotted on a growth chart. His actual weight was 13.4 kilos and dry weight was 12.5 kilos. Weight for length was about -0.5, so not too bad, but he was fluid overloaded, obviously. Labs are an essential part of the dietetic assessment. Daniel's urea level was a bit high, as were his cystatin C, phosphate, and potassium. Mom tells that he eats well when he's not down with a cold. His dietary intake was calculated by a 3-day food record, and his intake was 1,100 kilocalories, which was about 88 kilocalories per kilo towards his dry weight. And protein intake was nearly 4 grams per kilo dry weight. He was a bit slow to learn to eat due to his developmental delay, so he was fed with a spoon by his caregivers and was practicing using a spoon himself.
So what is the energy prescription going to be for this little boy? Well, we recommend that the initial prescription for energy intake should approximate that of healthy children of the same chronological age. And this is supported by those studies that you can see on the right side of your screen. 4 trials have studied resting energy expenditure or basal metabolic rate and have seen that there's no difference between healthy children and those with CKD after adjustment for lean body mass. This is further supported by a number of observational and retrospective studies where dietary intakes around 100% of energy requirements for the healthy population resulted in acceptable growth in both conservatively managed children and also those on PD. And in a large prospective trial of 51 children, normal growth was achieved with median energy intakes of about 100% of the estimated average requirement at baseline and at 2 years follow-up. So we have come up with a term called suggested dietary intake, and you can see these values in the table here for children aged 2 and onwards, both for boys and for girls. Now these values have been taken as an average from well-respected published national guidelines from the USA, from the UK, Nordic countries, the German-speaking countries of Germany, Switzerland, and Austria, New Zealand, Australia. So we've looked at a wide range of recommendations and taken an average of those. To promote optimal growth, then we recommend that you adjust the energy intake towards the higher end of the SDI. And for those children that are poorly grown with a length or height less than the 3rd centile, you use the height age for these children. So your starting point will be within these ranges that you see here, but trying to get your energy intake towards the upper end to promote adequate growth. And just as a reminder for those children on dialysis, then they will absorb some glucose from their dialysate, and you can see the figures there have been found in 2 studies. But this will all depend on the glucose concentration of the dialysate, the transporter status, the number of cycles, and the dwell time. So that's going to be highly individual. And for some children, that extra glucose will be a useful boost to their energy intake. But for those who are overweight, then it may be to a detriment, and that their energy intake prescription from their food, their diet, their feeds may need to be decreased a little to stop them becoming overweight. Next slide. So what are the protein requirements for children with CKD 2 to 5D? Well, there's much less evidence to support this. There have been 2 randomized control trials which compared a low protein versus a normal protein diet. One of them showed that a lower SDS for length and growth velocity in 24 infants who were on a low protein diet. But in a larger study with children, there was no growth difference between those on the lowest safe protein intake compared with those on an unrestricted protein intake. And indeed, a Cochrane meta-analysis has showed that there's some uncertainty over any possibility of harm associated with the provision of a strict low protein diet in the growth of young infants. But we know from our own personal experience, and this was the view of the Pediatric Renal Nutrition Task Force, that a low protein intake increases the risk of malnutrition, protein energy wasting, and poor growth. And so we have recommended that we should target protein at the upper end of requirements to promote optimal growth. And again, the figures that you see here are taken from those national published recommendations for protein intake that I mentioned just now. Just take into account that those figures on the left-hand side of the range, that lowest amount, that is actually the minimum safe amount, and you shouldn't reduce protein below that level, otherwise protein intake will become the restrictor of growth. And do just beware that if your baby or older child that you're looking after has low urea levels, much lower than would be indicated for their degree of renal failure, it may just indicate that they're getting insufficient dietary protein and you need to give them more. Now, if they have persistently high blood urea levels, then we suggest that you adjust the protein intake towards the lower end of the SDI, but first of all, exclude other causes of high blood urea, for example, chronic dehydration or steroid therapy. But do note that if you're giving inadequate energy intake, then some dietary protein will be used as a source of energy and can't be utilized for building lean tissue. Again, just a little alert about those on dialysis, that their protein intake may need to be higher, as shown here on both PD and HD, because there will be losses during the dialysis period. So what are we going to offer our children to eat? Next slide, please. Well, we want to offer a healthy, balanced diet with a wide variety of food choices, and these should be based, as for the normal population, on the 4 food groups: starchy carbohydrates, fruits and vegetables, protein foods, whether they're animal-based or plant-based, and dairy products. And we know from the CKD study of children with mild to moderate CKD that they have very undesirable eating habits, and that fast food provides a large amount of the sodium, phosphate, energy, and saturated fat intakes in their diet. So we want to give our kids with CKD a healthy, balanced diet, and a more liberal intake may actually encourage a more normal development of behaviours around food, because we've all been faced with a child who's reluctant to eat. But there may be other factors that impact on the willingness to eat, especially as children get older. Diets that are unnecessarily restrictive with multiple dietary prescriptions will automatically giving the child the idea that they can't eat food rather than us trying to promote a wide variety of foods. The foods that are permitted may be few and poorly presented, with very few ideas for the children of how they can eat, and the families can prepare meals. A child who acquires CKD later in life may find it more difficult to cope with restrictions. The one that's born with CKD, who's always been used to having some kind of restriction on what they can eat. Adolescents in particular wish to eat with their peers and increasingly rely on fast processed foods. And dietary education that we deliver may not be done in a very attractive way. And also we need to take into account the family's budget. They may have limited food choices due to the cost, and also where they live, the sorts of shops that they can actually buy their food from. Next slide, please. So there's a host of reasons why children may not take enough from their diet. Acidosis, anemia, and uremia negatively affect oral intake if not corrected. Appetite for both feeds and foods can be impacted by persistent gastroesophageal reflux, gut dysmotility, abnormal hormonal regulation. So we need to take into account the gut hormones like cholecystokinin, the cytokine ghrelin. These are all raised in CKD and have an effect on gut dysmotility. Older children have reduced smell and taste sensations, and this might also affect the infant's appetite, so that there's a reluctance to eat from a very early age. Also taking into account that polyuric children preferentially drink large amounts of water, and so that's also going to fill up their stomachs and reduce their appetites. And we all know about the polypharmacy that these children are on. The huge number of medications may further affect what they're prepared to put in their mouths because they're just fed up taking horrible tasting medicines. So if children do have inadequate dietary intake, we should first of all address any correctable medical causes. So as far as gastroesophageal reflux is concerned, consider feed thickeners, though in my own experience that has very little effect on these children's vomiting. Think about alginates, antacids, H2 receptor antagonists, protein pump inhibitors, prokinetics. If they are acidotic, then correct that with base supplementation. And for those on dialysis, consider if they're volume overloaded and improve their dialysis program. All of these correctable medical causes may actually solve your problem of the child having inadequate intake. Next slide, please. But once the deterioration in weight center is noted, there needs to be prompt intervention. And we recommend starting oral nutritional supplementation by encouraging high energy foods, but concentrating on those with a high nutritional value. So again, looking at the 4 food groups and choosing foods that you would normally have in a healthy diet. But actually there is space for carbohydrates and fats to be added by fortifying foods and drinks. And this can be done with a number of different energy supplements. If you have glucose polymer powders available, they can be used, and also there are glucose polymers which have fat supplements in them as well. These have a neutral taste and dissolve very easily in liquid or moist foods, and can be added to sweet foods like porridges, breakfast cereals, desserts. And they can be added to savoury foods like soup, mashed potatoes, vegetables, beans, lentil dishes, where they will dissolve quite nicely. You can use pure sugars, glucose, jams, honey and syrups, but of course they'll impart a sweet taste, which may limit their use. But these can be added to, again, breakfast cereals, spread on bread and toast and pancakes, and is a good way of getting some extra calories into the child. Fats can also be used like vegetable oils and vegetable spreads, and we recommend that you choose those with a high content of omega-3 fats like soya, walnut, linseed, or those which are high in monounsaturated fat, so that we're getting a better profile of fat when we're supplementing these children's diets. And these oils and spreads can be added to pulses, vegetables, rice. They can also be spread on toast, buns, etc. So an easy way to get some extra calories in. You can add glucose polymer powders to drinks at high concentration without an osmotic effect on the gut, and they can be added to plain water or water with fruit flavourings and cordials. Some add them to carbonated drinks, though they do tend to fizz up rather and explode over the side of the glass. You can also use those combined glucose and fat polymers. They impart a white colour to the drink, and they give a milky mouthfeel, which some children just don't like. But if you're using these glucose polymers, you can start with 5 grams added to 100 mils, and then gradually increase to a concentration of 30%, i.e. 30 grams added to 100 mils, as tolerated by the child. Sugar and glucose can be added to drinks, but again, the quantity might be limited because of the sweet taste, but also it will have an osmotic effect on the gut. And if you don't have olive oils and those high omega-3 fats available, then of course you can use the polyunsaturated fatty oils like corn, rapeseed, safflower oil. So use what's available, but use it judiciously. So back to Daniel.
Yes, thank you. Here you can see Daniel's growth chart again, and you can see that his height is starting to fall off his centiles as his kidney function gets worse. His growth was poor, although his weight for length was remained in the normal range, as you can see here. But at this point, we do need to intervene. Daniel eventually needed dialysis, and it was hospital-based hemo 3 times a week for various reasons. At this point, he was fluid overloaded and needed a fluid restriction of 600 milliliters per day. His protein goal was 2 grams per kilo, which is somewhat more than we usually aim at, but he was still losing some protein in urine as well as in the dialysis now. He had a poor appetite as well. His labs after starting hemo are shown here. His urea was 19, which is okay for someone on dialysis. His potassium and phosphate were in the normal range at this point, and albumin was 24, so still pretty low. For when Daniel was in hemo, his diet plan looked like this. We asked parents to give him 2 portions of meat or chicken or fish or pulses per day. 6 portions of cereal products per day. We would have liked him to eat one or two fruit or fruit purees per day, vegetables at every meal, and advised to give standard pediatric SIP feeds if he skips a meal. His fluid restriction was 600 mils per day, and the parents were asked to keep a list of his fluid intake at home. With declining appetite, his diet got poorer. Here you can see an example of his food record. We encouraged all the energy supplements we could think of to help him grow. He had vegetable spread and marmalade on his toast, some cookies and rice cake for snack. When he refused lunch, he was given a bottle of standard pediatric SIP feed. Here you can see a typical sized dinner for him, so about 100 grams of pasta and 2 meatballs with ketchup and a bit of cooked carrots. In the evening, again, some toast with marmalade plus some watermelon. He would drink 300 milliliters of cordial with glucose polymer mixed in during the whole day. His energy intake was good with the supplement, so 88 kilocalories per kilo and protein 1.7 grams per kilo. But without the SIP feeds and glucose polymer, it would have been much worse. Only 68 kilocalories per kilo and 1.5 grams per kilo of protein.
So you've just seen there how Daniel could have his diet supplemented, but we do know that some children are still unable to meet their nutritional requirements orally. And for these, we recommend a supplemental or exclusive enteral tube feeding. And 8 retrospective studies have shown an improvement in weight and BMI, standard deviation with tube feeding, in children less than 2 years of age. And 6 of these studies, encouragingly, also showed an improvement in height SDS. And again, we always think about tube feeding in infants, but a study from a group of children at Great Ormond Street Hospital, where tube feeding was started after 2 years of age, and these children were pre-pubertal, they showed an improvement in both their height and weight SDS. So this really does show very nicely that we can get improved growth with tube feeding in the older age group of children. Now, the full description of how to give your nutritional prescription by enteral feeding has been elucidated in this clinical practice recommendation here, but I will just say that nasogastric tube feeding is the preferred option for short-term feeding, and we're really just talking about a few weeks. But if we are talking about more long-term enteral feeding, 6 weeks or longer, then a gastrostomy device is recommended by whichever method it's placed, whether it's by your radiology teams, your gastroenterologists, or your surgeons. But as I said, all of those techniques and the pros and cons and pitfalls around that are well described in that clinical practice recommendation paper that I've shown you just there. So just let's have a look at enteral feeding in the next slide, please. What I've shown here is a typical standard pediatric formula, and they all have a very similar profile, the commercial available formulas, and they're all about 1 calorie per ml. But there can be situations when you need to add energy to a standard pediatric formula, and this may be because a child is catabolic, their urea levels may be rising, their potassium levels may be rising because they're using protein from their intake as a source of energy, and they're getting cell breakdown because they're catabolic. And so one of the ways to initially correct uremia and hyperkalemia is to add some energy to the formula. You can add glucose polymer, and the amounts that we'll probably be able to add safely are shown in the table here. So you can be adding between 8 and 18 grams of carbohydrate in the form of a glucose polymer to one of those standard pediatric feeds. You can also add fat emulsions, so these have a 50% fat content, 50% water, and again, if it's introduced gradually, then you should be able to add as much as 9 mils per 100 mils of formula, and by doing that, you're giving a good boost on the energy intake, and you may overcome some existing uremia. It's possible to add just glucose or sucrose if you don't have glucose polymers available, but of course they will increase the osmolality of the feed to a much greater extent and may cause vomiting or make any pre-existing diarrhea even worse. But a guide amount is probably about 4 grams per 100 mils. And again, if you don't have commercial fat emulsions available, then you can add an oil. Very little work has been done on that. Is it better to give those omega-3 fats that I've mentioned earlier? Is it better to give a monounsaturated fat? We don't really know. The amount that can be added is probably about 4 mils per 100 mils, which will have very little effect on the osmolality of the feed, but of course the fat does settle out. So if you're adding pure oils to an enteral formula, the reservoir that you're giving the feed from needs to be shaken very regularly in order to disperse the oil back into the feed, otherwise it will just settle out and the child won't get it. There are high-energy pediatric formulas which are available commercially, and these are more concentrated at 1.5 calories per mil. They're higher in protein, and these may fit the bill for the child that you're seeing. You just really need to match the profile of the feed with what the child's nutritional requirements are. The manufacturer's suggested usage for these high-energy feeds is between 1 and 12 years of age, of a child weighing about 8 to 30 kilos. Now, for older children, teenagers, adolescents, then it is possible to use standard adult enteral formulas, but you do need to look very carefully at the nutritional profile as regards their vitamin and mineral content, which may be excessive because obviously they're being designed for adult requirements, not for the requirements of childhood. So let's return to Daniel and see how he's getting on.
Thank you. Yes. Unfortunately, at one point, Daniel became poorly and had difficulties breathing. He had a short stay in the pediatric ICU where he received continuous hemo and some oxygen via nasal prongs. While this all was happening, Daniel refused eating altogether and a nasogastric tube was inserted. His fluid restriction was still 600 milliliters per day. He was hyperkalemic, possibly due to catabolism, because he wasn't eating properly. Therefore, for a little while, we switched him to a pediatric renal specific low potassium formula altogether, and he received this via his NG tube. You can get to quite low potassium intakes with using only a pediatric renal SIP feed, as you can see here on this table showing his dietary intake at this point. So after the hyperkalemia resolved, then he was switched to half and half renal specific and a standard SIP feed, which increased his potassium and phosphate intakes to more acceptable levels. He was always offered food and SIP feeds orally first before giving the feeds through his NG tube while he wasn't eating. But this was a temporary thing.
So we've been concentrating on giving adequate energy and protein for growth, but inevitably we will need to start modifying the dietary prescription for the child, and we will have a look at some of those aspects now. We know that the prevalence of hypophosphatemia increases with age, from 6% in young infants to 81% in adolescents. So as children get older, they're eating more phosphate, perhaps they're not being so compliant with their medications, but that high level of hypophosphatemia in our older patients needs to be addressed. Potassium intake will also increase with age, as has been shown in the CKD study, as children take more food, a greater variety of food, and actually eat more food. But conversely, potassium intake may also decrease as CKD advances if appetite is reduced. We need to think about salt, and a salt restriction is beneficial for many in the early stages of CKD, as it will reduce blood pressure and thereby slow down the decline in kidney function. And one aspect that we often don't think about is dietary calcium, but in fact, as a consequence of modifying the diet for lower phosphate intake, we're automatically reducing the amount of calcium that a child will take. And in Louise McAllister's study of some children at Great Ormond Street Hospital, she found that 3/4 of these children with CKD stages 4 to 5 and on dialysis had insufficient dietary calcium, which was largely due to the phosphate restriction that had been imposed on them. So we accept that we do need to have some dietary restrictions in order to control these children's blood levels and their blood pressure, but any restriction should be limited as much as possible because we don't want to worsen any pre-existing reluctance to eat. And what we need to do is to take an holistic approach. We need to consider the diet as a whole and not simply concentrate on nutrients as separate components of the diet. So we can't advise about phosphate without thinking, are there implications for other aspects of the diet? We can't advise on potassium and think, well, okay, we'll send them away with their potassium advice, but is that going to have an impact on the dietary adequacy as a whole? So what we really want to get across in looking after these older children, and indeed the age of any child with CKD, is that we take this holistic approach and that we as health professionals draw all these various aspects of the diet into a cohesive whole, so that we're not just talking about phosphate or potassium or salt, we bring it all together. But let's just have a look at those individual elements first of all, and then we can discuss a bit towards the end about how we can bring all that advice together. So let's have a look about phosphate first of all, because this is probably the first restriction that we need to place on the diet, because we know that phosphate retention and biochemical abnormalities are seen in children as early as stage 2 CKD. We recommend that dietary phosphate intake is kept within the suggested dietary intake in mild to moderate CKD, and you can see the SDIs for phosphate here for the various age groups. And if there's persistent hypophosphatemia or hypoparathyroidism, then we recommend that you aim for the lower limit of the SDI in order to control blood levels. Our first step in our dietary management of phosphate is to limit phosphate additives. And we recommend that families choose fresh foods to eat rather than processed foods. And you can see from this little diagram here that phosphate appears in so many different manufactured foods, whether they're baked goods, whether they're drinks, fast foods, bacon products, fish products, other chicken, meat. If you look at the label of any food, you're very likely to see this word phos. And that's what we teach the parents to look for if they wish to avoid manufactured foods that contain these additives. And what I've got in the table here are the E numbers that are used for these phosphate additives that are used in the EU. So our first step then is to limit phosphate additives. Next slide, please. But then we may need to reduce the intake of some foods which are naturally high in phosphate. And obviously the sources of dietary phosphate in a child's diet does vary geographically. And from food analyses taken from the UK and the USA, the main natural dietary sources of phosphate for children are milk and milk products, cereal and cereal products, meat and meat products. So if we're talking about restricting some of the foods which are high in phosphate, we really need to think about the bioavailability of phosphate because this does depend on the source of the food. Now, absorption of phosphate depends on whether it's organic or inorganic in a food, but also vitamin D status has a role to play, but we won't go into that now. So meats, fish and dairy products contain the phosphate, which is organically carbon bound, and the bioavailability of that phosphate from these foods is between 40 and 70%. If we look at plant-based organic phosphate, found like seeds, nuts, pulses, whole grains, well, that phosphate is stored in the form of phytate or phytic acid, which can't be digested by the human gut. And so much of that phosphate passes out undigested, and its bioavailability is only 30 to 40%. So we're absorbing less phosphate from these plant-based foods than we do from the animal-based foods. But look at this last bullet point, those inorganic salts, those phosphate additives which are added to processed foods, they're not organically bound or associated with phytate, and their bioavailability is up to 100%. And so you can see that we wish to restrict those additives because a huge amount of phosphate is going to be absorbed for families that rely very much on manufactured processed foods. And so our idea is to educate the family on the sources of dietary phosphate and to get them to use fresh foods wherever possible. So how does this impact on Daniel's intake?
This is exactly what we did with Daniel's diet. So to lower the phosphate intake, we first changed the turkey ham and sausages that Daniel liked to eat to ones without phosphate additives. The amounts of ham and sausages were limited also for reducing protein and salt intake. Luckily, Daniel still liked to eat ready-to-eat baby foods, which are naturally low in phosphate and have no phosphate additives, and are also low in salt. Family was also advised to prepare home-cooked meals from fresh foods, and Daniel's milk intake was reduced.
So let's have a look at potassium then. Potassium excretion isn't significantly affected until GFR falls below 15 to 20. So it's not usually a problem in children who have better renal function. But if a child is seen to be hyperkalemic, first of all, we must look at the non-dietary causes of hyperkalemia. For example, their medications may be giving them a large amount of potassium. Have they had a recent blood transfusion? Are they constipated? Have they lost that natural excretory route of the feces in order to get rid of dietary potassium? So it's important to us to remember that a dietary restriction is only necessary for those with hyperkalemia. And what I've shown here are the ranges that we have recommended for infants and for older children. And it's important not to think that these children need to have a potassium restriction simply because their kidneys are beginning to fail. Now, again, the main sources of dietary potassium will vary geographically, and this is data taken from not just the UK and the USA, but Europe as well. And the main natural dietary sources are milk and milk products, starchy roots and tubers like potatoes, vegetables, cereals, cereal products, fruit and fruit products, and meat. So for here, our first step is to limit the intake of high potassium foods and drinks with a low nutritional value. So what we want to target, first of all, are things like crisps, chocolate, coffee, ice creams, fruit juices, foods which contain a lot of potassium but don't offer very many other nutrients to the diet. And so what we want to offer, if we're giving foods which do have a potassium content, which of course all foods do, we want to go to the high nutritional value foods and drinks. So we want to be able to include milk, potatoes, vegetables, pulses, cereals, fruits and vegetables, meats, etc. But the amount of these may need to be limited. But again, this is very individual, and a diet prescription needs to be given for each child rather than just handing out dietary information that isn't tailored to the individual family. Next slide, please. So the next stage then, very much like I just described with phosphate, is to educate the families to reading packaging labels and to avoid potassium additives. And there you can see the E numbers of the potassium additives which are commonly used in the EU, and the sort of label that you might see on a packaged food. And again, this is all because of the bioavailability of that potassium, that the bioavailability in unprocessed plant foods isn't more than 50 to 60%. But if we look at animal foods and fruit juices, where you've obviously taken the fiber away from the fruit, then that bioavailability is much higher and maybe up to 70%. But the demon in the piece, again, are these processed foods which have potassium additives, because that bioavailability is much greater, up to 100%. And so again, by cutting out foods which have an addition of potassium additives, can really save a lot of potassium so that the child can eat more foods which are naturally high in potassium, because you've taken away that potassium you really don't want that's found in processed foods. The next stage for controlling dietary potassium is that you can adjust the cooking methods. And there are very many ways that you can do this. And one of the easiest things is this double boiling method, particularly of potatoes, because they are high in potassium and they're popular with children. By double boiling the potatoes, bringing to the boil, throwing away the water, putting fresh water in, bringing it to the boil again, that can reduce the potassium by 50%. But there are other methods as well, which I haven't got time to describe here. But it is important to point out cooking techniques which should be avoided, like stir frying, cooking in a tagine, because these methods concentrate the potassium content of the food. And also, if families are wanting to have potatoes, not to use jacket potatoes, but to use that double boiling method that I mentioned just now. So we've already looked at how phosphate restriction is affecting what Daniel can eat. How's the potassium restriction going to affect him now?
Yes, Daniel did have high potassium levels at several points. We had the chance to give him SIP feeds. So the first thing we did was to change the standard SIP feeds to first an adult low potassium SIP feed and later to a pediatric low potassium SIP feed. Like Vanessa said, I would like to put in a word of caution using adult SIP feeds for children. You need to make sure that no vitamin or trace element intake is excessive. But at least the low protein options can sometimes be used as a small part of the diet if pediatric renal SIP feeds are not available. In addition to the SIP feeds, Daniel's milk product intake was limited to a minimum. His family was advised to choose vegetables from a low potassium range and to either omit potatoes or double boil them, diced and discard the cooking water, as Vanessa just described. But we were sort of lucky in that Daniel was not eating that much fat food or pre-packaged food, so the E. colis were not that much of a problem in his diet.
So let's just have a quick look at renal-specific feeds, which are low in potassium and also have a low phosphate content. Here's a typical example of an infant renal formula at an energy concentration of 1 calorie per ml. And you can see it has appreciably lower potassium and lower phosphate content than a whey-based infant formula. And these low potassium, although they're called infant formulas, can of course be used for children over 1 year of age. There's now a range of pediatric renal formula that's available. These are more concentrated in energy at 2 calories per ml, but again have an appreciably lower potassium and phosphate content compared with standard pediatric formulas. I've given an example here of an adult renal formula, and again, we will keep saying do take care with their nutritional profile for children. This one is particularly high in protein, but there are others which have a lower protein content, but it's the vitamins and minerals which are likely to be excessive in these products if you're using them for a child. So let's just have a look at our final electrolyte here, and this is calcium, which we did mention earlier on. And for the SDIs for calcium, you can see them here in the table, and we recommend that calcium intake should be within and up to 2 times the upper limit of the SDI value. And in order to have good bone health, again, just to say that the phosphate intake should be within the SDI and limit those phosphate additives. But as I mentioned a little earlier, how do we provide sufficient calcium while controlling phosphate intake? Because if you start to cut down on the higher phosphate foods, you inevitably start to cut down on calcium intake. Well, you can give non-dairy calcium-rich foods like green leafy vegetables, beans, nuts and nut butters, and also some foods are fortified with calcium in some countries like bread and breakfast cereals. But again, just going back to McAllister's study of those children at Great Ormond Street, and remember again, 3/4 of those children had insufficient calcium, it's almost certain that additional calcium will be needed from medications to meet requirements. You probably won't get enough from diet. And this can be done with by counting the calcium that comes from calcium phosphate binders, but it may be necessary to give calcium supplements in addition. So let's take a look about calcium in Daniel's diet.
Yes, so in Daniel's diet, calcium intake was definitely a concern because we had to limit his milk intake to a minimum for phosphate and potassium management. And he did not really like to eat vegetables and other foods with a high calcium content. His dietary calcium intake was only 100 milligrams per day when he was not taking SIP feeds. He needed calcium-based phosphate binders, 750 milligrams per day, so that provided him calcium. However, at one point, when he was dialyzed more frequently and his dietary intake altogether was low, his phosphate also became low in his blood. And at that point, we began giving the calcium supplement in between meals for better absorption. And then we reduced it to 500 milligrams per day to meet the SDI.
So let's think about one final important aspect of the diet, and that's fiber. And the importance of fiber in the diet in children with CKD is gaining more and more traction. And in fact, we as the Nutrition Task Force are in the process of writing clinical practice recommendations about fiber for children with kidney diseases. And that's out for a Delphi consultation at the moment, and hopefully that paper will be published towards the end of this year. But here's just a few headlines. We all know that fiber is an essential part of a healthy diet, and there are indeed benefits for children with CKD in that it prevents constipation. And as we mentioned before, potassium is excreted in the feces. Children with CKD have fewer GI symptoms. They have a reduced inflammatory state, and a decreased production of gut-derived uremic toxins, and that's been very nicely described in a paper we published last year. Plant-based foods also contain high amounts of anions, which mitigate metabolic acidosis, so they're very useful in CKD in that respect. And as for children without CKD, plant-based foods, as well as providing fiber, have a host of other nutritional benefits, like providing vitamins, minerals, flavonols, polyphenols, phytochemicals, etc. And indeed, because they have a lower protein content, plant-based foods may be preferable to animal-based foods if you need to start cutting down protein if there are high urea levels. And of course, we must remember that half the population of the world already have a plant-based diet and don't eat animal-based foods. So there can't be anything too far wrong with having a plant-based diet. But these high fiber foods have been traditionally targeted in the so-called renal diet. Pulses and whole grain foods have been omitted because of their high phosphate content, and vegetables, pulses and fruits have been avoided due to their high potassium content. But the headline really is don't routinely omit these foods from the diet based simply on their phosphate or potassium content, because as we mentioned earlier, the bioavailability of phosphate from plant-based foods is much less at 30 to 40%, and potassium bioavailability from plant-based foods is only 50 to 60%. So including pulses, whole grains, vegetables, fruits must be considered and shouldn't automatically be targeted and reduced and avoided in a child with CKD. So let's just have a look in the next slide at how we're going to try and meet the challenge of how we provide a varied diet while controlling phosphate, potassium, and salt intakes. And indeed, we have just written a paper which describes everything that we have been talking about for this last 50 minutes or so. And we hope that this will be published at the beginning of next year. And this is the table that's taken from that paper. And this is really to show, going through the food groups, showing lower phosphate options, lower potassium options, and ways to reduce the sodium intake, apart from the obvious thing of not adding salt at the table or cooking, and not adding salt at table or adding salt in cooking. Just to remind you that although we're talking about children here, breast milk and weight-dominant infant formulas may still be given to these children and indeed may be preferable because of their low phosphate and potassium content, and of course they're naturally low in sodium as well. Excuse me. But we give examples of using plant-based milks, which are going to be acceptable, but obviously watching out for that additive of calcium phosphate, which obviously isn't going to render a plant-based milk low in phosphate. Going through cheeses and yogurts which are suitable and showing what the lower salt alternatives are. And again, encouraging starchy foods, not avoiding those which are high in fiber, pointing out starchy foods which are high in potassium, and it really is potatoes that we're targeting here, and we've already spoken about those. And as far as salt's concerned, avoiding those products that have salt added to them, like crisps, and instant meals like pastas, rice and noodles, and checking the salt content of breakfast cereals, because often those which have a lower sugar content have a higher salt content to give them a bit more flavour. And again, looking at meat, chicken and fish to look at the unprocessed type so that you're not getting the phosphate additives, you're not getting the potassium additives, and also salt is added in quite large quantities to most processed foods. Next slide, please. Eggs on the whole, if you pardon the pun, aren't a problem, but if you're looking for a lower phosphate alternative, go for the egg whites. And then, of course, we're looking at pulses, and this is, again, looking at plant-based sources of protein, lentils, dals, split peas, the whole range of them, with just a few to point out which are high in potassium, like black-eyed beans, broad beans, and butter beans. And making sure that if you're using canned pulses, that they don't have salt added. So again, most brands these days are just canned in water, whereas not so long ago they were always canned in brine, which is salted water. getting more nuts and seeds into the diet, again as a source of plant-based protein, avoiding the salted varieties, and also being aware of the high potassium seeds, which are the pumpkin seeds. Vegetables and fruits, as I said, to be encouraged wherever possible, but taking into account they may need to be taken in reduced amounts. But again, this needs to be done individually with the child and not as a blanket approach. And just to be aware of those which are high in potassium, like avocados, Brussels sprouts, okra, plantains, sweet potatoes, and those fruits which are high in potassium, like apricots, bananas, melon. It doesn't mean these foods cannot be eaten, but they may need to be taken in restricted amounts. And again, that punchline at the bottom, do avoid food additives so that you're not wasting, if you like, your diet by taking potassium, phosphate and salt from those highly processed foods when you could be using good natural foods instead. Next slide, please. And just to round up on our dietary advice, vitamins, minerals and trace elements, the task force is looking at this, and we hope that we will publish a paper on vitamin requirements, vitamin requirements for children with CKD, and we hope that paper will come out towards the end of the year. But until then, we will keep with the advice provided by KDOKI to provide at least 100% of dietary reference values for healthy children, with a supplement if dietary intake is insufficient, with again the reminder that those on dialysis will need a water-soluble vitamin, and those for PD and hemo I've listed there. The exception is vitamin A, because we know that these children will lose the kidney as a route of excretion of vitamin A, and increased retinol levels have been reported even without supplementation, and is associated with hypercalcemia. And again, the other exception is vitamin D. There are already recommendations for native and active vitamin D supplementation, which has been produced by the ESPN, and we won't go into vitamin D because that is a chapter all of its own. So let's see what's happened to Daniel and what the future holds for him.
Yes. After his visit to the PKU, Daniel started eating again, and he had the NG tube removed. His urea levels were higher than we liked, so the protein goal was adapted downwards from the 2 grams per kilo per day that it initially was. He also needed the phosphate and potassium, as well as sodium and fluid restrictions, as just discussed. He was having no milk products, phosphate or potassium additives, and he was encouraged to eat fruits and vegetables, but choosing from the low potassium range. His protein needs were met with 2 tablespoons of meat or chicken or fish per day, and 1 to 2 slices of cold cuts, which he liked on his toast. He ate 6 portions of cereal products per day, and with these, high fiber options were encouraged. And he was also encouraged to eat vegetables on bread and with meals, but he was somewhat picky and accepted only cucumber and capsicums and carrots. For energy, he was getting 3 to 4 tablespoons of vegetable oil or spread, and cordial to drink, and some glucose polymer mixed in with the cordia. We also had a sort of a just-in-case plan for the parents. So if he refused breakfast or an afternoon or evening snack, he was given 50 mils of renal-specific SIP feed. And if he refused lunch or dinner, he was given 200 mils of standard pediatric SIP feed. For vitamins and minerals, he received a multivitamin mineral supplement without vitamin A or iodine. His vitamin D supplementation was tailored according to lab values and was usually 10 or 20 micrograms per day. What we really need to remember is that we have to work with what the child is willing to eat, although we are aiming for a healthy diet. A couple of months later, we encountered persistently high potassium and phosphate levels. We checked for non-dietary causes for these at first. There was no constipation, but there may have been a catabolism due to lack of energy, as calculated from his food record that you can see here on the side. His protein needs were higher than usual, which made the potassium and phosphate management trickier than it normally is. We obviously checked his diet for any additives, and there were none. Potassium intake from fruits was also low because he was only willing to eat about 50 mils of fruit puree per day. However, he did want ketchup with every meal, otherwise he wouldn't eat anything. We also found out that the SIP feeds and fat supplement was not consistent, which may have led to the insufficient energy intake. So the food record was calculated and energy intake was way below the SDI for his age, and his protein intake was much lower than what was planned. He also had very low dietary intakes of calcium, phosphate, and almost all vitamin and trace element intakes were below 50% of recommended. He did receive calcium supplement and the multivitamin mineral supplement to reach the recommended intakes. At this point, we also advise to give SIP feeds every day. We need to tailor our advice according to the parent's capacity to modify the diet. Some can estimate food amounts and give SIP feeds as top-ups as needed, while others will need a more straightforward diet plan. The diet modifications we did at this point were to ensure sufficient energy intake. We did this by regular use of the SIP feeds, by increasing the amount of glucose polymer to 50 grams per day, and by reminding that vegetable oil needs to be given regularly at every meal. We also discussed using less ketchup, but this little fella needed a little on his plate, otherwise he wouldn't eat anything. We also started him on potassium binding medication for his days off from hemo. His potassium levels just seemed quite difficult to control by any other means on a thrice weekly hemo. And for phosphate management, we increased the calcium-based phosphate binders to a total of 1.5 grams per day, which was still consistent with the SDI. And then finally, at the age of 5 years, he received a kidney from a deceased donor. For the first 3 months, his fluid needs were high to keep the adult-sized kidney running, and getting all the fluid in was a struggle. He reacted to all the changes by refusing to eat, so he needed an NG tube again. We started him on a standard 1 kilocalorie per meal pediatric enteral feed with fiber. Initially, the amount was to cover all of his energy needs, but the amount was gradually decreased to allow for hunger, but still he got water top-ups to cover his fluid needs. Eventually, we achieved some diversity in his diet, and now he accepts a larger variety of vegetables and fruits and berries, and is eating an unrestricted diet, and he's just doing really well. And that brings us to the end of our presentation now. So now it's time for your questions. So please send your questions via the chat.
Hello, everybody. First of all, thank you so much, Vanessa, and thank you, Jetta, so much for this great webinar. A lot of very useful information, and I really appreciated the message that we need to have an holistic approach to the diet, which is really complicated, but it's important to look at the diet as a whole and not at a single component. So this is really an important message in my mind. Thank you so much for that. And under this point of view, I think that the case of Daniel is a very, very good example. So thank you again. Now let's move to the questions. We have already some nice questions here. And if any one of you has a question, please just write it on the chat and I'll be more than happy to read it for our great speakers. Let's start with a question about phosphate here for patients on dialysis. Can you, and about the need for phosphate restriction in patients already on dialysis. Is it really needed? We know that controlling phosphate is not easy in patients with dialysis as well. So maybe yes, but let's, I don't know, maybe Vanessa, do you want to comment on that, maybe?
Well,
Please.
I think it's important to say that phosphate restriction does need to start right from the beginning, because as I mentioned in the talk, that phosphate retention occurs very early on in CKD. And I think it's good to get the families used to the idea that they can't have an unrestricted amount of phosphate in the diet, because inevitably that is going to become a problem as time goes by. So whether a child's on dialysis or not, I guess of course you have to be guided by the serum levels, but I think it's unlikely that even if a child's on dialysis that they're going to be on a free phosphate allowance in their diet. I think it's something that for their long-term bone health and to avoiding hyperphosphatemia, hyperparathyroidism, I think a phosphate restriction of some sort is inevitable. But again, it's something that needs to be individualized, and you need to take into account the family circumstances. But I can't really see a situation where you wouldn't have some kind of phosphate restriction.
Except maybe for a continuous dialysis or a home hemo where that can be done every day, then that might be a case where you don't need that much of a restriction.
Absolutely great point. Thank you. And now here, and here we have a question concerning the education, which is obviously an important point. And the question is, do you feel that those patients, families who have more dietetic input, maybe attending any events or group education, feel better with the phosphate calcium levels than those who don't? So how important is it to the education under this point of view?
Yes. So regular reminding and regular checkups are obviously essential in keeping with the diet, and the patients, they need encouragement and reminder to be able to follow the diet that they need. I don't actually have experience in educational or group events, so I can't comment on that, but definitely regular follow-ups are good for the patients, but even then it's up to the family's capacity and how well they are able to manage their child. So there's many different aspects that can influence the phosphate management and dietary management.
I would just like to add that the Pediatric Renal Nutrition Task Force is currently undertaking a research project called the Impact Study, where we're looking at how parents and children want to be educated, because we don't want to be seen as dishing out the advice and in the wrong form, in a way that's either unattractive or not understandable. And so this work, which we hope is going to have a European collaboration and has started in the UK, we're asking children and their carers what they know about their diet, and this is all around phosphate management to start with, what they know about their diet, how they would like to receive the message. Do they want to have one-to-one interviews with a dietitian or the doctor? Do they want to meet in groups? Do they want visual materials? Do they want videos? Do they want apps? Do they want diet sheets? So we hope that if we can glean from the children and their families how they want to be educated, then we can target our education to the way that best suits their learning needs. And we hope that if we teach them what they want to hear, then there's a greater chance of them being able to comply with the advice that we're giving them. And after all, what we want is a better outcome for them. But maybe some of our education falls on deaf ears because we're not delivering it in the right way.
Thank you. And my personal question here, strictly related to this point, is concerning adolescents, because all of you know that it's particularly difficult to care for adolescents as regards diet, so to obtain a good compliance to the diet. How is it possible, if it's possible, to educate adolescents to low phosphate diet, for example? Do you have any suggestions under this point of view?
I think it is important to acknowledge their lifestyles. I think that's the first thing. And not to be punitive. I think one always has to be encouraging, to listen to what they have to say, to listen to what their lifestyle is. And if they do want to go out to the fast food restaurant or whatever, not to say no, say, yes, you can do this with your friends, but what I would like you to do is perhaps go for this and avoid that. And I think it's always very important to be with the positives, what they can eat. Of course, you're going to have some conversation about what they can't eat, but I think it's always got to be on the positive. This is what you can do. This is how we can fit in our advice with how you want to live your life. But they also need to know what the consequences are. I mean, they're going to have to take on their own management once they hit 16 or 18 and go to an adult service. They need to start to learn what the consequences are of not being compliant with their diet and knowing that it has a long-term effect on their health.
Thank you. And now let's move to calories. And someone is asking here, do you find that the SDI overestimate calorie needs for some patients? It has been noticed that even with at the lower end of the range, we have a high amount of calories, or can be maybe too high for some patients in healthy BMI ranges. So the question is, why do we need all these calories? Probably. Any comments on that? Maybe Jetta?
Well, the energy needs are individual. So for some the lower end of the SDI range is okay, and some need to be the upper end of the SDI range. But absolutely, you need to look at how the child is growing and the weight and the height, and checking those regularly, so you're not giving too much or too little.
And it's just important to remember that the SDIs are derived from national recommendations, which are set at the 50th centile. So those are the requirements which are right for 50% of the population. So there will be those that need more, and there will be those that need less. And so the only way to judge that is by titrating, if you like, the energy intake against the child's rate of weight gain, and reducing if you need to. If it falls below the SDI, so be it, if that's correct for that individual child.
Thank you. Thank you so much. We have a couple of questions on potassium. The first one concerned catabolism. Does catabolism cause hyperkalemia? Maybe Vanessa, we want to answer this question?
Well, if the child's catabolic, then they're going to start to break down tissue. And once you start to break down tissue, you release potassium, and that potassium goes into the bloodstream. Now, some of that is going to be excreted by the kidney, but the majority is going to be excreted through the gut, through feces. So if you can reverse the catabolism by giving more energy, then you will stop that cell breakdown and the hyperkalemia may resolve. So it is important to make sure that a child's getting sufficient energy if you start to see their potassium levels rising. Obviously, if it's catastrophically high, and if it's above 6, that's emergency, and you're not going to start giving energy supplements, you're going to take emergency action. But if you start to see the child's potassium starting to rise towards the higher end of the acceptable range, then one of the things is to check that they're not catabolic. Have a look at their growth, have a look at their weight gain. If their weight is static, they're catabolic, and so they need more energy.
Yes. Thank you. And maybe the same problem concerns hyperazotemia. Do you agree? Like turbulence can be also associated with increased urea levels, not only potassium. Do you agree with that?
Yes, it's a similar argument, isn't it? That if you're catabolic, you're not getting enough non-protein energy, you start to break down lean tissue in your body as a source of energy, and the byproduct of that is urea, and serum urea levels start to rise. So again, if you can give more non-protein energy, then you will stop that breakdown of lean tissue.
Perfect. And coming back to potassium, there is a question on the potassium variability here, because the question is, I did observe patients starting on dialysis may experience low potassium for a short period of time and then hyperkalemia. What is your recommendations? Maybe Jetta, do you have any comments on this change from a hypo to hyperkalemia during dialysis?
In that case, you would just need to react to the situation and adjust accordingly. So if there's low potassium, then you may give the child more high potassium foods, and then when he becomes hyperkalemic, then go to the lower potassium range, and always make sure that the energy intake is sufficient, so that's and there's no other causes of hypo or hyperkalemia.
Absolutely, it's important. I agree on this. It's important to adapt the prescription, and for example, the residual kidney function probably can justify these changes in nutritional needs, actually. And this is, then we have here a very practical question. What challenges are faced when using adult renal products in pediatric patients? Do you use this kind of products on a regular basis in your daily clinical activity? Maybe Vanessa?
Yes, adult products are used, and I mean, the advantages of the adult products is that they're high in energy, and that's often what we're searching for. But it's important to look at the range of products that are available, because they're not all identical. Some have higher protein contents than others, and indeed the one that I showed as an example in the talk was 7 grams of protein per 100 mils, which is probably too high for most children, but there are other products that have half that amount of protein in. They may well be lower in phosphate and potassium, because that's what they're designed for, to be low in those two electrolytes. But again, they are designed to meet the energy, the protein, the vitamin and mineral content of a 70-kilo man, not a 15-kilo child. And so it's looking at that profile of vitamins and minerals, which is particularly important. Now, whether that's problematic in the long term will be revealed when our vitamin clinical practice recommendations are published later in the year. So I don't want to give too much away there, because Jetta has done a lot of work on that. So I don't know if you wanted to add anything, Jetta, to that.
No, well, well, just to add that if I need to use adult feeds, then I would tend to calculate all the vitamin and mineral intakes with an electronic software, so that I know what I'm giving and know that I'm not giving too much. I know those are not available throughout the world, but that's my practice.
Great, thank you again. There is another very practical question here. In practice, is there any way to estimate the potassium and phosphate actual intake according to their bioavailability? How it is possible to do it in the real life? Maybe Jetta, I don't know, or Vanessa.
Well, first of all, you can never know exactly how much, excuse me, phosphate or potassium a child's having in their diet, because those amounts just aren't published for processed foods. And I think there are probably very few children who just have natural foods in their diet. So as soon as you start to take into account that they're having any kind of processed food, you don't know what their exact potassium or phosphate intake is, because those contents just aren't published on labels, and it's very difficult to get that information from food companies in any case, and those levels may change according to which batch is going through the factory at the time. But the part of the question which I think is really interesting is, in the future, will we be able to adjust how much of these foods we allow according on the bioavailability of the potassium and phosphate? And I think that is going to be something that will be working more in the future. And we may well be able to say, well, these foods are desirable because they have a lower bioavailability. These are the ones you need to take more care with because they have a higher bioavailability. But I don't think we have that kind of information at the moment. I don't know if you want to add to that, Jette.
To add, also the cooking methods will affect the calcium and phosphate content. So yes, whoever is asking this question is absolutely right in that we don't actually know the exact amounts that we're giving. But if we look at the blood results, we usually know whether we need to give more or less, and that is something that we can adjust.
And that's the key, isn't it? It's seeing the physiological effect. That there's no point knowing how much is in the diet. We need to know the effect it's having. And some children will be able to have higher amounts of phosphate, potassium, whatever, than others, because their own absorption, gut absorption, is going to be different, quite apart from the bioavailability from doing experiments in the lab of how much of those minerals are extracted from foods. I think the message is that, you know, the renal diet is highly individual, and that we can't just give advice that we think is going to suit a group of children. It's got to be done for the individual.
Great point. Actually, I think we have time for another question, and maybe we have here another question here for you. With all this data restriction possible in a child with CKD, would you introduce some restrictions, for example, on phosphate, even from the time of weaning an infant, or would you wait to see what level of kidney function they ultimately end up with? Would you comment on that? Jette, what do you think about this option?
Yes, I would definitely start a phosphate restriction right from the start, at least the E codes. So natural foods that are high in phosphate would probably be okay at that point. But restricting the additives is essential from the beginning. We don't want to wait. But please, Vanessa, add anything if you like.
I absolutely agree with that. I think right from weaning we need to think about a phosphate restriction, because we don't actually know whether that baby's renal function is going to settle out until they're a year or older, because we know that there's maturation of kidney function throughout the first year for many of these children. So I think it's better to start with a phosphate restriction. And then if you find that a child who had a hugely high creatinine as an infant has pretty much normal renal function by the time they're a year of age, and of course you relax the diet. It doesn't mean that having started a phosphate restriction, that's what's going to continue. So I think during the first year of life, it is better to have that phosphate restriction and then relax it once you have a better idea of what the actual renal function is.
Perfect. Thank you so much. I think we need to stop here, but thank you again, Vanessa and Jette, for this great webinar. I learned a lot, really. And thank you so much, all of you, for your attention today.
Thank you.
Thank you.
Vitaflow would like to thank our speakers and chair for taking part in the webinar today. On this slide, you will see all the publications from the Paediatric Renal Nutrition Task Force to date, which are available open access in paediatric nephrology, and the associated webinar recordings are available on VitaFlow's Via platform for viewing. The next presentation by the Paediatric Renal Nutrition Task Force will be on the 15th of January 2024 and will focus on dietary fibre in paediatric kidney disease. On behalf of VitaFlow, we would like to thank you for tuning in. Please take the time to complete the feedback survey sent to you by email after this webinar. Goodbye and enjoy the rest of your day.